I tried to sort of make this what I think most people would want to hear about. So hopefully I hit your favorite topics with NTM. We obviously can't cover everything, but we'll give it a good try. So talking about non-tuberculous mycobacteria infections in people with CF today. So things that we will cover today, what NTM is and why CF makes it more likely, how it's diagnosed, how it's treated, areas of research in NTM infection, and then your CF clinic and questions to bring with you, particularly if you end up culturing positive for NTM. So what are non-tuberculous mycobacteria? So here's a picture of them on the right. Sort of another name for them. Some people call them red snappers because they stain red under the microscope. And mycobacteria are slow-growing bacteria with a thick cell wall that contains mycolic acid, hence the name mycobacteria, which makes them resistant to many antibiotics and disinfectants. They exclude members of the M. tuberculosis complex that cause TB or the disease tuberculosis, and that's why they're called non-tuberculous mycobacteria. They are acid-fast, meaning that they can be visualized under a microscope with a specialized staining technique, leading to another moniker, AFB, for acid-fast bacilli. And sort of in your clinic, we will use the terms AFB and NTM kind of interchangeably. Technically, AFB includes TB, but if somebody is talking to you about AFB, they are generally talking about NTM in the context of CF. Oops. And then most people with normal immune systems and no lung disease will see these bacteria every day and never develop infection because they're very common in the environment, which is sort of the next thing that we'll talk about is where do they come from? They are hardy organisms that survive in many everyday environments, which is why they're so hard to avoid completely. And really, you can't avoid them completely. I think trying to avoid them completely is sort of a losing task. They are found in household water, also hospital water. They're found in shower heads, faucets, hot tubs, humidifiers. That's why, if you come to clinic and tell us you're using a humidifier, we sort of get a panicked look on our face. It's okay to use a humidifier, but you need to sort of clean it every single day and dry it out sort of every single day so that these NTM can't grow in that. They are in soil and dust. They're in gardening soil, potting mix, in the environment, in the woods. Anything that can be stirred up can aerosolize NTM. And then they do have everyday resistance, so they can survive many disinfectants and harsh conditions. So you can have the cleanest bathroom in America and you can still have NTM hiding in your shower head and your faucet. And this is a little bit terrifying, but one study found that NTM were present in 8 out of 10 household water supplies. So very ubiquitous in our environment. So who gets NTM infection? People with CF. That's why we're having this conversation. But it's not just people with CF. White, middle-aged, or older men with a smoking history and COPD get NTM. So we see a lot of this in sort of older men with severe emphysema. Non-smoke, interestingly, it happens, I would say, most commonly outside of CF in non-smoking women over 50. And particularly in tall, thin white women with rib cage deformities, particularly something known as pectus excavatum, scoliosis, or mitral valve prolapse. And we don't exactly know why mitral valve prolapse is sort of associated with NTM, but this is sort of the typical patient that you'll see. There's an increased incidence in individuals with CFTR variants, so-called CF carriers, and then people with pre-existing bronchiectasis from prior TB or other severe infection. And there is a sort of geographic predilection to NTM infection with an incidence highest in the Southeast United States and in the coastal states. Where I worked in Virginia, we had a lot more NTM than we do in Massachusetts, although we do have a significant amount of NTM infection in Massachusetts as well. Why are people with CF more prone to getting NTM infections? Like other infections, the thicker, stickier mucus lets bacteria settle in and linger in the airways longer than they should. Impaired mucociliary clearance means the lungs can't sweep the organisms out as effectively. And an existing airway damage, such as cavities or bronchiectatic airways, creates these sort of pockets where NTM can sort of take hold and set up shop. So there are many NTM organisms. This is a list taken from one of our journals. It's very many. I wouldn't expect you to sort of be able to sort of absorb all of this. But just to point out that NTM is not just a pulmonary infection. So NTM is most commonly a pulmonary infection, and that's why it's here at the top. But you can get NTM infection in other organ systems as well. Usually this requires some type of structural or immune deficiency, some type of structural problem or immune deficiency. It doesn't happen to just normal people with normal immune systems. It happens in people with HIV, people with lung transplants, people with other solid organ transplants, but really a high burden of disease with NTM species kind of worldwide. But we are going to talk the most today about these two species that matter the most in CF, but they are not the only species that cause problems in people with CF. And the two that we take care of the most are Mycobacterium avium complex and Mycobacterium abscessus. And Mycobacterium avium complex is a group of organisms that sort of have similar characteristics and similar drug sensitivities and are sort of phylogenetically related. And this is the most frequently seen NTM group overall. I would say it's the most frequently seen NTM group in CF and non-CF. It's most often seen in older individuals, not in children or young adults. And it's generally the most treatable with your kind of standard drug regimens, although like everything, there's exceptions to everything. And then Mycobacterium abscessus is the other one. And Mycobacterium abscessus, there's really two subspecies that are the most important. And I was talking sort of before, Mycobacterium abscessus is the most problematic one. Mycobacterium abscessus macilliens is the other one that we see. They both are more resistant to antibiotics than MAC, than Mycobacterium avium. But Mycobacterium abscessus is the sort of most resistant species. As I said, it's naturally resistant to many antibiotics, and it's linked to the most new NTM lung disease cases. So most new acquisitions sort of tend to be abscessus, and happens in younger patients. You can see this in children even with CF, and treatment is longer and more complex than treatment for MAC. So I think this is an interesting slide. This is taken from one of our ATS journals, from one of our American Thoracic Society journals, and they looked at people who were 40 to 60 who had a positive NTM culture in the blue, and then they looked at people who were greater than 60 in the orange with a positive sputum culture. And then they looked at within those groups when those individuals were diagnosed. And interestingly, if you were diagnosed later in life, you're more likely to have an NTM infection. And I think the sort of correlate to this is that it tends to happen, it can happen in milder lung disease, right? Because if you have more severe lung disease, you're more likely to be diagnosed early. Or if you have sort of typical delta F508 genetics, you're more likely to be diagnosed early. And so this really tends to be a disease of sort of milder lung disease and sort of non-traditional CF variants, CF genetics. I mean, that's not to say that people who are delta F508 homozygous don't get NTM, but it is really a spectrum of people who get this with CF. And the highest prevalence of NTM positive sputum cultures actually happens in people who were diagnosed in adulthood. And this here is a picture of Fern Leitman, who's the founder of this group called the NTM Information and Research, NTMIR. This is their website. But she was a woman who was diagnosed first with NTM infection, and then after having been found to have an NTM infection, was diagnosed with CF. And I would say this happens incredibly frequently, that an older woman, and it tends to be older women in particular, are diagnosed with NTM infection and subsequently tested for CF and then found to have CF, sort of usually with atypical or unusual genetics. And this is just one example. And then I'm going to show you a couple things from the CF registry. So as many of you know, the CF Foundation and the European CF Foundation, but this is data from the American CF Foundation, keep a registry. If you've given consent, then your data from your sputum cultures are included in this national registry of people with cystic fibrosis. This is from 2023, but the data hasn't changed that much. And CF guidelines recommend that individuals with CF who can expectorate sputum should be cultured for non-tuberculous mycobacteria at least once annually. And so what is shown here is a picture, in the gray bars are all comers with CF in the registry. The blue bars are if they produce sputum, and then the red bars are if they have a mycobacterial culture performed. So as you can see, we are capturing probably less than half of people with CF in terms of any kind of sputum culture, and even less of those are getting mycobacterial cultures performed on an annual basis. And for the most part, that's because people with CF don't make as much sputum when on sort of highly effective modulators, and that has been a problem in sort of managing many infections recently in the sort of highly effective modulator era, but particularly with NTM, it's very hard to screen people for NTM if they're not making sputum. And this is shown kind of just graphically here that we're capturing about 50% of people with CF with our annual screening who are adults, even fewer who are children. And that's a problem that is not easily fixed. And then we talked about the different types of NTM organisms that are problematic in people with CF, and this is just quantitative in 2023 in the CF registry. So there were 514 people who tested positive for MAC in their sputum, and 337 who tested positive for M. abscessus or M. colonize. And then again, I told you that there are other mycobacteria that cause problems in people with CF, but by far and away, these are the two sort of most common. And then in all comers with CF, the percent of people with CF with a mycobacterial culture with at least one positive culture. In 2019, which was sort of the last year before the highly effective modulators were in sort of common use, it was 13.9%. And it has been less over the past few years, 10.3, 10.1, 12, and 12. It's hard to know if this is significant, and we'll talk a little bit more about that. But in 2025, 12% of all people with CF had at least one culture positive for NTM, which is pretty high, and maybe higher than you would think, maybe higher than people here would think. And then by age group, this was a study done in Germany, actually, looking at all comers in the German registry for CF, and the colors are different age groups. And this is all comers with CF based on their ages, and this is any NTM. But I just want to show you that this is M. abscessus here, and this is MAC. And you can see M. abscessus is largely a disease of younger people, the sort of dark green and dark blue and dark red here. And then MAC tends to be a disease of relatively older people, the kind of adults in the room 30 and above. And how do mycobacterial infections affect people's lung function? And this is an open-ended question that I think we don't fully have the answer to in the highly effective modulator era. But prior to the highly effective modulators, what we knew was that M. abscessus has the most significant impact on rate of FEV1 decline. And again, FEV1 is sort of what we follow when we do your PFTs. It stands for forced expiratory volume in 1 second, or how much air you can blast out in 1 second. And that's what we track kind of over time to monitor your lung function, and M. abscessus caused the most significant decline in that number compared to all other CF pathogens. So if you look at this graph, this is sort of a hypothetical graph based on data that they collected of, if you acquired the organism at this point in time, this is the sort of expected rate of decline without any kind of concomitant infections. But if you acquired the organism at this time, what would happen to your lung function? And again, this is no chronic infection. You would expect to sort of just have ongoing decline over time. MAVM, MAC, or MAC doesn't have a significant a significant effect on your lung function. It's sort of better tolerated. This is Stenotrophomonas. Pseudomonas, our friend Pseudomonas, is here, sort of in the middle. This is a Chromobacter. This is the dreaded B. cepacia, and then M. abscessus is sort of causes the most rapid rate of lung decline compared to all of these organisms. So again, you asked me which was the worst actor, and abscessus is definitely the worst actor. It tends to cause more cavitary disease. It tends to sort of be more tissue destructive than other NTM species, and therefore kind of leads to worsening lung function. But again, this is data from the pre-modulator era in CF care, and we just don't have good data on post-modulator, era. We just don't have good data on post-modulator lung function effects yet. So I will show you kind of what data we do have, which is not great data, but this is sort of what we have. So this was done, this was published in 2022, but only included data through 2018. So this was all collected prior to Trikafta or Liftrec, which are considered the highly effective modulators. But this would include Kalydeco, Orkambi, and Symdeko. And again, this looking on the y-axis of the likelihood of having an NTM positive culture over time. And if you're not on a CFTR modulator, you are more likely to have an NTM positive culture than if you are on a CFTR modulator. And they looked at combination therapies, which at this time would have included Orkambi and Symdeko, or monotherapy, which at this time it still would be just Kalydeco. And it really didn't matter if you were on Kalydeco, Orkambi, or Symdeko. They were similar, and it was better than being on no CFTR modulator. But again, this doesn't include Trikafta, this doesn't include Liftrec, and so it's very hard to predict what those highly effective modulators are going to do. We have very poor data on on NTM cultures after ETI. This is a single center's experience published in 2024, and they just looked at the annual number of positive NTM isolations 2 years before starting ETI, which is Trikafta, 1 year before starting ETI, Trikafta, and then 1 year after starting ETI. And they saw a significant decline in the number of NTM positive cultures 1 year after starting ETI. And then they looked at the species, and it was only significant really in Mycobacterium abscessus. So they saw fewer M. abscessus positive cultures after starting ETI. But again, these are super small numbers, single center, lots of sort of caveats to this data. So we're going to move on to sort of how we diagnose NTM pulmonary disease. And I think the important thing to sort of point out first is that having an NTM positive sputum culture does not equal NTM pulmonary disease. So NTM pulmonary disease is sort of what we would consider treating. It's when you have a positive NTM culture and we think the NTM is actually causing sort of illness, is causing progressive lung disease, is causing problems in the lung, and not just sitting there kind of neutral. So NTM pulmonary disease is kind of what we would consider treating and is separate from NTM positive cultures. And so symptoms of NTM pulmonary disease overlap 100% with regular CF exacerbations. And so that's exactly sort of why your care team relies on cultures, imaging, and not just symptoms alone, as well as like pulmonary function testing, and we sort of try to collect all the data that we can. But the symptoms of NTM pulmonary disease are very similar to other symptoms you may have from CF exacerbations, which include increased fatigue or low energy, unexplained weight loss, worsening cough or no sputum changes, increased shortness of breath, low-grade fevers, or night sweats. So very non-specific symptoms. Sometimes you can have hemoptysis as well. And so when do physicians start to suspect that NTM may be playing a role? So when you have chronic or worsening respiratory symptoms that are not explained by typical bacteria, and usually this correlates with the below one here, which is when you really don't get better when you're getting standard antibiotics for the organisms that we know you're colonized with. So failure to improve with standard antibiotics for typical CF organisms is sort of a big red flag. So far, is there something else going on? Is there another organism that we need to be worried about? Increased cough, sputum production, or hemoptysis without another clear cause. So it doesn't look like your pathogens have changed. It doesn't look like much else has changed in your CF care, but you're having more symptoms. And then we rely a lot on imaging. So we rely a lot on changes in imaging. So, most people with cystic fibrosis will have bronchiectasis or tree and bud opacities or mucus plugging, which all can be hallmarks of NTM infection. So we look for kind of progressive changes on CT. So once you have a positive sputum, then you'll probably be asked to get a chest CT, looking to sort of see if there's any new changes. We look for newer worsening nodular tree and bud opacities, cavitary disease, or progressive bronchiectasis or consolidations. And then we look at your lung function. So declining lung function, FEV1, out of proportion to other infections or treatments. If you're not responding to antibiotics with a recovery of FEV1, we start to worry. And then need for frequent hospitalizations or antibiotic exposure. So if you're seeing a ton of antibiotics continuing to come in the hospital, then we might suspect NTM infection. So how do we diagnose NTM pulmonary disease? So again, we talked about this already. So the first step is routine screening. So everybody should be screened annually, even if you're not having symptoms. And that relies on sputum cultures, which again is problematic in many people who don't make sputum. And then if you have a positive sputum, we'll confirm it with repeat testing. So we will never treat, I won't say never, because never is a strong word, but almost never treat with a single positive culture. So we would confirm with repeat testing and look for the same organism on multiple sputum cultures. Again, we'll look at the imaging, and then we'll have a sort of multidisciplinary discussion, weighing in on cultures, imaging, and symptoms together, including the patients, and sort of talking about next steps. And how do we culture NTM? So it's very different from your typical bacterial cultures. Most clinics can send both cultures on the same sputum sample. So you don't have to give two sputum samples, but they are sent to very different places and processed in very different ways. So again, sometimes there's not enough volume to do both cultures. But in our clinic, if a patient produces sputum, we send it almost every time for both testing, for routine bacterial testing, for regular CF pathogens, bacterial pathogens, and then also for NTM. But these organisms can only be cultured and identified in specialized labs. Our lab does not do this. So even at Brigham and Women's Hospital in Boston, we don't do our own NTM culture. At Boston Children's Hospital, we send it to the state lab in Massachusetts, and at Brigham and Women's, we actually send it to Quest. So we farm these out because the sort of expertise and labor involved in culturing NTM usually is not cost effective for most hospitals. And you have to be good at it in order to do it well. So they send it to specialized labs that do this all of the time. So again, many hospitals have to send their cultures to a centralized lab. The identification is often done by specialized molecular biology techniques. So once you have a positive culture, they'll take that organism and put it on a slide and use specialized molecular biology techniques. And it's a specialized technique it's actually called MALDI-TOF, which is kind of, if you know anything about kind of chemistry or molecular biology, it's a mass spec kind of system that identifies the organisms, and that requires even more expertise. And once you have a positive culture, you need to send that to even more specialized labs for drug sensitivity testing prior to any treatment consideration. So we actually take every isolate from every patient and send it for drug sensitivity testing before we would ever treat somebody, to make sure that the antibiotics that we're planning to use are going to be effective against an individual patient's isolate. And I would say most of these cultures are sent to either National Jewish in Colorado or University of Texas in Tyler. So there's two kind of NTM drug susceptibility testing meccas in the United States, and they are in Texas and Colorado. So all of our cultures go to those two places, and I would imagine across the country that's the same thing. And there are guidelines for this. So there are guidelines for how to diagnose and treat NTM. And so these are sort of the major guideline documents that I'm going to take some of this information from. Just so you know, we're not sort of operating in a data-free zone. And we kind of talked about how to diagnose it, but this is the actual guideline here. So again, you need clinical and microbiologic criteria for the diagnosis of non-tuberculous mycobacterial pulmonary disease. So you need symptoms, you need changes on your chest CT, both are required. You need to appropriately exclude other diagnoses, so other bacterial exacerbations or other reasons that someone could be having declining lung function. And then the microbiologic criteria are very clearly laid out. You need positive culture results from at least 2 separate expectorated sputum samples. If the results are non-diagnostic, consider repeat sputum AFB smears and cultures, or a positive culture result from at least 1 bronchial wash or lavage, or a transbronchial or other lung biopsy with mycobacterial histologic features and positive culture. But we almost never do lung biopsies for this. So for most people, it's going to be 2 positive sputum cultures or 1 positive culture from a bronchoalveolar lavage. And again, we talked about sort of how it's hard to get sputum cultures on many people. And if there's a high enough suspicion for NTM infection, your doctor may talk to you about doing a bronchoscopy looking for this. And this is sort of the flow chart of how they recommend sort of diagnosing NTM pulmonary disease. And I put this up here because, even if you follow the flow chart, you have 2 or more samples positive for the same NTM species. This is a high resolution chest CT. Your chest CT is consistent with NTM pulmonary disease. You have the right symptoms, and you can be diagnosed with NTM pulmonary disease. It still just says consider treatment. There's you don't have to treat everyone with NTM pulmonary disease. And I think that is sort of something that's a hard thing to kind of get your head around, that not everybody will be treated. But the treatment is very intense. It has a lot of toxicities, and not everyone who is diagnosed with NTM pulmonary disease will be treated. And that's the next slide. Not everyone needs treatment right away. So your team will weigh treatment against watchful waiting based on whether your cultures stay persistently positive, whether the symptoms are actually sort of significant and worsening, whether your imaging shows active progressive changes, the specific NTM species and its resistance pattern. If you have a very drug-resistant organism, then the risks of sort of creating more drug resistance may outweigh the benefit of treatment, and then your other CF treatments and your overall health. I think your age and sort of your kind of clinical picture comes into this a lot, because again, not everyone can tolerate treatment, and so we need to sort of make sure that people are in a good position to sort of commit to a treatment course like this. And then treatment is a serious commitment. It's many months of multiple medications with significant side effects. And so that's why this decision is made together and not automatically at the first positive culture or even the second positive culture. Looking at the big picture for treatment, it's 3 or more medications used together at minimum, sometimes 4, including both IV and oral antibiotics. And it is at least 12 months of therapy, very often longer. 12 months is the absolute minimum, and that is if everything goes perfectly. I know people with abscesses who've been treated for 5 or 6 years. So this is a commitment. This is a long-term project to treat these organisms. Regimens are individualized by species, drug resistance testing, disease extent, and how you tolerate the treatment. There is no single standard dose or standard plan for everyone. It also has to do with sort of what other medications you're on, because there's drug-drug interactions. So sometimes we have to modify the regimen based on other medications. So treating MAC, again, it's a multi-drug regimen, but it's usually a macrolide antibiotic, usually azithromycin, which is a macrolide, plus 2 other oral drugs taken together. In people not on an effective modulator, not on a CFTR modulator, that's usually rifampin and ethambutol. But in people on modulators, they can't take rifampin because of drug-drug interactions, so we don't use rifampin. So we will substitute, so it'll usually be azithromycin, ethambutol, and another drug of which there are kind of multiple options. It's a sustained course, so you continue this for at least 12 months after cultures turn negative. So even if your culture turns negative the first month after treatment, then you're still treated for 13 months. So you need a year of treatment after negative culture. And then we do regular sputum cultures to confirm the treatment is effective. Treating M. abscessus is a little bit more intense. I will say with MAC, sometimes we do, if you have very severe disease with cavitary disease particularly, there will be an IV treatment up front, but very often we can get away with just orals. But with M. abscessus, we always do IV therapy up front. It's usually, for abscessus, it's usually IV antibiotics for 12 weeks. For Myceliens, it can be a little bit less, but 3 months of very toxic IV medications, including IV amikacin, which requires extensive laboratory monitoring, looking at kidney function, and has significant ototoxicity, ear toxicity, and vestibular toxicity, which is sort of just your balance system. So we really worry about people on IV amikacin for 12 weeks. And then we combine that with several oral or inhaled drugs. Again, at least 3 drugs that are effective against the organism. And then after those 12 weeks, you move into a continuation phase, which is generally oral and is at least 3 drugs. And then the course length, it generally takes longer to clear the cultures. You still will treat for at least 12 months after negative cultures, but tends to be longer than MAC and closely tailored to how you are doing. I want to highlight that the CF Foundation is studying NTM. So there's 2 trials open, the PREDICT and PATIENCE trials, which are really just observational. They're not interventional, but they want to see how people with NTM positive cultures progress and how they do on treatment. So this is a 2-part initiative designed to improve and standardize the diagnosis and treatment of NTM pulmonary disease. So again, there's PREDICT, which is the prospective evaluation of NTM disease and cystic fibrosis. And to be a part of this study, you just have to have a single positive culture, and then you're just followed over time to see what happens. And then there's the PATIENCE trial, which is the prospective algorithm for treatment of NTM and cystic fibrosis. And so what this trial does is gives a suggested algorithm for NTM treatment, and then follows how people do on that algorithm. But again, it's observational, so a physician can change the treatment plan in any way that they want to. They don't have to follow the sort of strict guidelines of the trial. These are open at many sites across the country, so I would this is a plug to engage in research. Observational trials have very little risk, and we can learn a lot. If you do end up culturing positive, please add your information because we need to learn more about this. And then these next 2 slides are actually taken from the from the information that they put out with this trial. So this is a list of drugs that are used to treat NTM infections. And again, they're unusual drugs. They're not drugs that you're going to have seen much of if you don't have NTM infection. Many of you probably have taken doxycycline or azithromycin or Bactrim. But aside from that, these are kind of more unusual drugs. And I put this up here just to show all of the toxicity monitoring that has to be done when you're on these medications. So again, you're on at least 3, usually 4 of these at a time, and getting all of these risks, all of these toxicities, and all of this monitoring. And this is a schedule of sort of the monitoring that has to happen for each of these medications. So again, monthly labs when you're on IV amikacin, weekly labs, audiograms, visual checks, following levels, peripheral neuropathy, following EKGs, getting LFTs, very intensive, lots of blood draws, lots of clinic visits, lots of time spent in care of these infections. And then the duration of treatment, again, is at least 12 months. So you're doing this for at least 12 months after culture conversion, guided by imaging and drug tolerance. And then I added this because when we think about treating NTM infection, we think about antibiotic treatment, but really one of the mainstays of NTM treatment is airway clearance. And airway clearance is really essential in NTM treatment. And when we think about infections of any source, let's say you have like a skin abscess, we talk about something called source control, where the abscess can't be resolved until it's drained. Like you can't treat something unless you've gone to the source and gotten rid of sort of the pocket of pus or whatever. And in NTM infections, airway clearance is that source control. So airway clearance is the way we sort of optimize antibiotic efficacy. And so why does airway clearance matter so much? Because NTM really thrives in thick airway secretions. And so airway clearance helps reduce the mucus and the overall NTM burden. And it also improves delivery of antibiotics to the site of infection. So you can't get antibiotics through thick, sticky mucus in the airway. So you really need the organisms to be sort of against the airway wall in order to ever see the systemic antibiotics. So you really need to get out as much mucus as you can. So it improves delivery of antibiotics to the site of the infection, both systemic and inhaled antibiotics, and supports recovery of lung function and exercise capacity. So during NTM treatment, we'll ask you to continue airway clearance, often increasing the frequency and intensity of airway clearance, and combine multiple modalities when appropriate. So we use bronchodilators, the nebulized medications, hypertonic saline, pulmozyme, sometimes NAC. We'll use PEP, which is positive expiratory pressure device, better known as a flutter, an acapella, or an aerobica. We use the vest, and exercise is also excellent airway clearance. So again, it's not an adjunct to NTM therapy, it's a core component of treatment. So you really need airway clearance and antibiotics. And who is going to be on your NTM care team? Based on everything that we've just talked about, you will have your primary pulmonologist who's going to be leading your overall care plan and probably help make the decision of when you need to be treated. Oftentimes, but not always, we will involve an infectious disease specialist, particularly if the organism isn't more unusual, or if it's sort of the resistance pattern is a little bit unusual. A CF pharmacist is critical to this. They will be the one who look for drug-drug interactions. They will often be the ones who are managing labs and toxicities. They'll be the ones talking to you about side effects. They'll be the ones adjusting the dosing. The CF pharmacists are sort of worth their weight in gold in these kind of treatment decisions. Respiratory therapist will talk to you about airway clearance, and your inhaled therapists. And then you need audiology and other specialists to sort of monitor your hearing, vision, organ function, and help manage side effects. So again, a multidisciplinary team is of critical importance in this. We can't do it by ourselves. And then I was just going to chat a little bit about new frontiers in NTM treatment and research in NTM treatment, because as you can kind of tell from what I was already talking about, these are not great treatment plans. Like doing a year of highly toxic antibiotics is not a great plan. And it would be great if we had less toxic and more effective ways to treat these infections. And so one of the sort of things that is being explored are bacteriophages. And if you've been around CF for any length of time, which many of you have, you've heard about phage therapy. Phage therapy is exciting in mycobacterial infections, but also exciting in drug-resistant infections such as Pseudomonas or Burkholderia. So why are these? So bacteriophages are viruses that infect bacteria or mycobacteria. This cartoon sort of is a picture of what they look like. They are kind of these geometric viruses that sort of attack bacteria. Why are they interesting? They are very highly specific. So you can target a bacteria specific to a patient. So a single patient's isolate, you can find a phage that is specific to that. They are self-amplifying, so phages can replicate at the site of infection when susceptible bacteria are present, which makes them even more effective. And they are particularly attractive for multi-drug resistant infections because they are very highly specified for that infection and have minimal toxicities. So very promising. Right now, one of the major limitations to this is that there aren't great phages that have been found in nature. So right now, the way we find phages for specific isolates is they go basically out into the environment and they scrape sort of trash bins, and they scrape the edges of rivers, and they scrape the environment, and they isolate phages from that. And they make these gigantic libraries of phages. And then when you have an isolate, you essentially have to screen that isolate against these giant libraries of phages to see which phages can kill that isolate. And it's hugely labor intensive, and it's very often you can't find a phage that will that will kill that specific isolate. And there are almost no phages that will attack MAC. There are some that attack abscessus, but almost zero that attack MAC. I won't say zero, but it's much less common to find a phage that will work on MAC. So again, there's a lot of drawbacks to this, and we'll talk a little bit more about that, but very promising for abscessus right now, particularly. And this is a paper that was published in 2022 by the group in Colorado. It just highlights one specific patient's experience with bacteriophages for M. abscessus. And I think this is sort of just a cool study that they did on this individual patient. So they took an individual who had M. abscessus infection for greater than 4 years and very highly drug resistant at that point. They had not cleared the infection, and then gave them phages over the course of a year, and then took them to lung transplant, and they did well. So, and what they saw was that M. abscessus did not require resistance to the phages, and eradication occurred despite a partial anti-phage antibody response. So you can develop sort of your own personal immune response to the phages, but even though this individual did develop an immune response to the phages, they were still successful at clearing the organism. And I just think this is a very interesting graph to look at. So this is time on the x-axis here. And so time 0 is when they received the phage treatment, and the green line is when they got a lung transplant. And then you kind of go backwards in time, and on the y-axis is their lung function. And then up here are the NTM cultures. So black is a negative culture, blue is actually a positive culture for MAC, and then red is a positive culture for M. abscessus. And so you can see that they were treated with multiple drugs. So the blue and the gray bars here are all the drugs that they took, starting 5 or 6 years before the phage therapy on multiple drugs. Lung function continued to decline. They were given phages for 1 year, got a lung transplant, and did not have recurrence of their NTM infection, which is quite remarkable. So again, just a very promising treatment strategy for these infections with much less toxicity than the standard regimens. And then there's only one paper published looking at compassionate use of phages in 20 patients with drug-resistant mycobacterial disease. So this is sort of the first 20 patients that did this. And again, this is mostly out of both Pittsburgh and Colorado. And they screened 200 NTM isolates. So 200 isolates were submitted for this trial. They were only able to find phages to treat 20. So again, only about 10% of people who wanted to enroll in this trial could be treated. So again, that's a huge limitation at this point. 17 of 20 of them were M. abscessus, like we talked about. 14 of 20 were people with CF, both adults and children. There were no adverse reactions attributable to the phage. There was a favorable clinic or microbiologic response in about half the patients, and neutralizing antibodies or an immune response by the individual to the phage was observed in 8 people. So again, they treated 10%. Only half of those had a positive response. So we are very early here, but something to look at. And this company is trying to commercialize phages, so more to come in this space. They are looking to sort of commercialize patient-tailored phages, so you may see more of this in the future. And I just put this out there because I think it's very interesting. This was a paper published at the end of last year that basically used AI to develop novel bacteriophages. And I think this is something that if we can use AI or other tools to basically engineer phages for specific organisms, that's going to be sort of that's going to be a revolution in phage therapy, because right now, again, the limitation is finding phages that are specific to an individual patient's isolate. And then other areas of research in NTM pulmonary disease. So again, I don't want to talk too long here, but there are other studies kind of looking at other therapies for these infections, looking at different inhaled antibiotics. So we already use something called ALIS, which is amikacin liposomal inhalation suspension. So it's essentially a encapsulated amikacin product that is better tolerated than non-encapsulated amikacin. We already use that, but they're looking at other inhaled antibiotics, including something called clofazimine. They're looking at inhaled molgramostim, which is a white blood cell stimulating medication, which basically makes the immune cells in your lungs work better and help. Then you can sort of clear the infection better yourself. They're looking at inhaled gallium compounds. Gallium is a heavy metal that sort of mimics iron and disrupts bacterial metabolism because bacteria need iron, and so they die that way because it blocks the iron absorption. They're looking at inhaled nitric oxide. And then one interesting thing is up till now in the United States, when we treat NTM, we're really treating for cure. We're really treating for negative cultures. But in Europe and other places, they don't always treat for cure, they treat for control. And so, I think that is something that we may see more of, is that maybe you get a course of NTM-directed antibiotics to sort of like you would to Pseudomonas, where we're not expecting to eradicate it, but we're just expecting to improve symptoms in FEV1 for a period of time. But there's no data on that right now, and it'll be interesting to see if we sort of change the way we address this over the coming years. And then I just want to point, last year they published at our annual conference a very small study on omadacycline monotherapy. And omadacycline is a pretty well-tolerated oral antibiotic. It's in the family of doxycycline, which people do very well with and don't have a ton of side effects from. And that's different than most of the NTM therapies. And they've never really studied single drug therapy for these infections before. So this is one of the first studies looking at single drug therapy. And this was all people with M. abscessus. It was not all people with CF, but it was all people with M. abscessus. And you can see if you look at omadacycline versus placebo, again, only 40 patients in the omadacycline group and 25 in the placebo group. But these are sort of quality of life metrics. Like they felt much better on omadacycline than they did on placebo. And there was actually some improvement in sputum. So people had less abscessus in their sputum, and about half the people actually converted their sputum to negative with single drug therapy. So this is something too that is very interesting because it's a much better tolerated plan for people than multiple drugs over a whole year. And then sort of just wanted to touch briefly on infection prevention and control. So when you go to clinic, it is still not fully clear whether NTM can spread person to person, but there is some evidence of sharing strains person to person. We think that most NTM infections are acquired kind of through environmental exposure, but there is concern that you can spread it in the hospital, you can spread it in an CF clinic like you can with other CF organisms. So we do, just like everything else, we use standard infection prevention and control for these organisms, just like we would do for any other CF pathogen. So again, you'd be spaced apart or scheduled separately in clinic, similar to what we do now, but it is effective for NTM as well as bacteria. And so what should you ask? Things to ask if you particularly in regards to NTM infection, particularly if you've tested positive when you go to clinic. So you want to ask sort of, have I been screened for NTM infection this year? Did you collect my sputum for NTM? Because you should have. If I made sputum, it should have been sent for AFB. If I have a positive culture, is there enough evidence that I have NTM pulmonary disease? Do I need treatment now, or are we watching and waiting? Which species do I have, and what does that mean for treatment? What side effects should I watch for, and how will I be monitored? How will this affect my other CF medications and routines? What else can I do to support my treatment regarding airway clearance? And what can I do at home to reduce my exposure? And then just some take-home points from this talk. NTM are common, and a positive culture is not a crisis or a reason to panic, but it is a reason to sort of do more exploration. NTM pulmonary disease can present with varied symptoms, and therefore regular screenings and clinic appointments are important. We really need to know if your lung function is going up, going down, staying the same. And in order to do that, we need to see you more than once or twice a year. So it's important to get regular sputum cultures and regular PFTs. A culture positive for NTM does not necessarily indicate NTM pulmonary disease. And the decision to treat NTM pulmonary disease should be carefully considered over a period of weeks to months. And the decision to treat NTM pulmonary disease is a commitment on the part of both the patient and the care team for close toxicity monitoring and long-term therapy. And then finally, we are in desperate need of new treatment options for NTM pulmonary disease with increased efficacy and decreased toxicity.